Changes to the nurses and nursing process post-COVID-19. Welcome to my presentation. My aim with this presentation is to make reflections about what is the change of need in take care of and being taken care of post-COVID. My name is Mariann Aaland. I'm an intensive care nurse. I'm head of the day surgery unit at Akershus University Hospital, president of the Norwegian Association of Ambulatory Surgery, and member of the executive committee in the EIIS. I'm also the host of the International Congress in 2024. And as you can see on the small mark on the map, I come from Norway, which is a small country up north in Scandinavia. My background, talking to you now, is with the background of my experience from our university hospital in Norway. It's also the experience of other members of the Norwegian Association of Day Surgery and also input from our colleagues in Denmark. Our hospital have had the biggest day surgery unit. We have the biggest day surgery unit in Norway with 12 operating theaters. Our hospital have had the biggest amount of COVID-19 patients in Norway. Our intensive care unit normally have 8 to 10 patients on a respirator. And on the top, we had 20 ICU COVID-19 patients in addition to the ordinary ICU patients. And also in addition, we had the intensive light without the respirator on NIV and so on, and a number of COVID patients isolated in the in-bed units. Our hospital has one of the best figures of surviving the virus after IC treatment. Norway, as I said, it's a small country with about 5.4 million inhabitants. And this is some key figures from our Norwegian Institute for Public Health. We have tested about 1.5 million people. The reported cases is about 17,000. Admittance to the hospital until now is about 1,200. Admitted to the ICU in total is 253 and 279 deaths altogether. The restrictions after the COVID situation started seems to be quite similar in many countries. Denmark, our neighbor country, practically are testing all before admittance to the DCU. So is also the case in several DCUs in Norway. Or all the patients with an aerosol-exposed intervention are tested before arrival, even asymptomatic. Relatives are not allowed in the DCU, and they are hardly allowed to come inside the hospital. Of course, one parent might join the child. There is a checkpoint at entering the hospital. I think most of the hospitals do that. All patients will get an SMS to be told not to travel abroad 10 days before admittance, and even to go to green countries is not allowed. Regulations are changing according to the present national restriction, as I guess it is continuously changing in many countries. At our hospital, we have the checklist. We actually have that as a routine since 2010. But in this checklist, we now included the questions about COVID-19. Known positive COVID-19, acute airways problem with or without close contact with anybody with confirmed COVID-19, quarantine, or traveling abroad the last 10 days. If yes, in any of the above, the surgery will be postponed or planned and performed in the in-bed unit at the COVID-19 area. The questions will also be repeated on the day of admittance. The acute grey zone patients, which need to be at the surgery quite fast, are defined negative as the next 24 hours after a negative COVID test. And most of the units I have contacted do the same or even have longer checklists. So the patient's experience post-COVID. I think the patient would say that the hospital feel less welcoming. They have experienced cancellations because of capacity or COVID-19 suspicions. More masks on both patients and healthcare providers. The checkpoint at entering the hospital. The patients are afraid to come to the hospital due to the COVID-19. They are afraid to bring the virus with them to the hospital, and they are also afraid that they could be affected by the virus at the hospital. It is very difficult for many to be without their relative at the hospital. In Norway, we do the handshake as a polite way to treat each other, and now the handshake does not exist anymore. So there is the nurses' experience. The nurses say that a lot of following up and checking according to the COVID-19 could lead to losing focus on other important issues. And we are very, very busy about that point because we don't want this to have any influence at the patient safety. The pathways, time-wise, might be less effective because there are extra checking. Also, the more physical distance automatically feels, it makes a sense of distance between the care receiver and the caregiver. The possibility to comfort the patient is limited. The support by close, holding a hand, to hug a scared mother who gave her child to us to perform anesthetics and surgery does not exist anymore. We lose parts of the non-verbal communication due to wearing the masks. There are tools to alleviate the stress. The most important is the information, and the written or information is the key. Also the oral, but the written is also important because the relatives are not longer present to receive the oral information from the doctor or nurse together with the patients. We need to have the predictable pathways to tell the patients about those, focus on the challenge to keep the patients giving the feeling of trust that we know about the problems, and we are doing something about it so they don't feel that they will be infected and so on at the hospital. The eye contact is important because some of the other non-verbal communication is not easy to make anymore. And the physical and mental presence, and also the clinical communication. I would like to tell you a story. This is Rikke. She's working at my day surgery unit. And this is her story from expert and back to beginner. She's a nurse since 2002. She is an operating theater nurse since 2009. She has been working in the day surgery unit since 2012. She's clever, intelligent, reflected. She's grown up. And in Benner's 5 steps from novice to expert, she is definitive an expert. And you can see the steps on the picture to the right. In the day surgery unit, Rikke has totally control in the operating theater. She has control over the instruments. She has nice and familiar colleagues. She is the type of surgery is well known. The procedures are predictable. And the patients is ASA 1 or 2 in the satellite unit where Rikke is working. She's free from work, holidays and weekends, nights and evenings, and she planned our life due to that. So the COVID-19 appeared. For our hospital, it was the critical situation happens in March, not close to Easter. Our DCU unit was closed the 12th of March. The next morning, the intensive care nurses and anesthetic nurses in the DCU were moved to the intensive care unit. After a few days of anxiety, some tears, a lot of news reading, 2 days of training, Rikke and her surgical nurse colleagues are also transferred to the intensive care unit. But nurses, doctors, other healthcare providers, always ready to help no matter what. And Rikke was scared, but she was ready, and she was proud to contribute. When she arrived at the intensive care unit, the patient group was totally new. It was ASA 4 and 5, and these patients were really sick. The new virus was new and unpredictable. The colleagues were new working environment, totally different procedures. Rikke has never been to an ICU before. Staying in the patient room the whole shift, except by maybe by lunch break, even alone. She was working shift, Easter and weekends. The nurses were also very scared to bring the virus home to the loved ones. There was lack of infection control equipment. That was also why they had to stay in the patient room the whole day. And the total unpredictable time perspective concerning how things would escalate and when to end was also a stress moment. So what changes did we do at our day surgery unit? All the day surgery nurses were relocated to the ICU. The DCU changed into a big COVID-19 cohort. We were planning 4 ICU patients per operating theater. The skilled DCU specialist nurses, especially the surgical nurses, felt terrible to stand in a situation where they felt like beginners. And also the ECU, they need help. There was a very limited time to train. The nurses were afraid to do something wrong, and they were also asking the question, who would be held responsible if they did something wrong? The rest of Norway and many other countries was closed down. The nurses and the doctors were working double. So what did we as leaders at the hospital do to support? We made debriefing teams with psychologists. We had repeating telephone contact with our staff. Sometimes every day we were talking to them in the telephone. We were trying to keep things predictable. Of course, information. Things were changing very, very fast from day to day, and sometimes from hour to hour. We made the WhatsApp groups, and we also make talking groups with colleagues where they could talk together about their experiences. That was very well, they liked that very much. It was important. And also we did more of the training classes. We made stress coping classes because the situation was new at work, but it was also new in life. We were trying our best. So what are the changes? 15% of our experts are now not back in the day surgery unit. Hanne, our Danish colleague, said 5 of my nurses are now gone. If another peak is coming up, probably the rest of them will also be gone. They quit because they don't want to do this again. They don't want to go from expert back to beginners in 48 hours again. The day surgery unit runs with reduced capacity. The waiting lists are increasing. The remaining personnel is running even faster. The COVID-19 situation will not end yet. Rikke, she's now a college teacher. She's not back to work at the day surgery unit, but she will voluntarily be back to help if needed. How can we make our skilled professionals stay? I do certainly not have all the answer. The biggest change for the nurses and nursing processes is that we now live with constant anxiety. This anxiety is constant for all health workers around the world. I think we need to tell the politicians and the public what a tremendous job our colleagues performed and still are performing. And I am quite sure that the nurses from the day surgery units did a better job than they thought themselves that they were doing. Because they are so used to have control. And in this situation, they felt that it was not good enough. We have to make areas where the healthcare providers can talk together to process feelings and experiences, and maybe some professional help. Of course, the cultures and the countries are not similar, and they solve the challenges differently, and so it has to be, but I think the basic is quite similar for all of us. So at least what we have to do is acknowledge that this is a problem and reflect on the subject. Thank you for paying attention. I wish you welcome to Norway for the 15th EIS Congress in Oslo 2024.